feet Pablo Cardinal Fernandez, Carmelo Dueñas, Guillermo Ortiz, and Luis Blanche. It's a fantastic program that you've put together. And we're now ready to start the session 3, which is about monitoring and supporting respiratory function. And I believe our first speaker, Gonzalo Hernandez, is going to be speaking to us from the auditorium in Madrid. So over to you, and I'll ask everybody who's on the call who's not speaking to please mute your microphones.
Or morning or whatever to everybody around the world. It's my pleasure to participate in this innovative online session. I would like to thank the organizers for the invitation. Well, I have a conflict of interest with Fisher & Paykel. It's one of the companies manufacturing high-flow devices. Well, the title of my lecture includes two possibilities: the use of non-invasive ventilation or high flow after an extubation. First of all, I want to say that these two options are directly compared in patients at high risk for extubation failure. But I want to say that patients at low risk are also analyzed in a specific trial published last year by your group that obtained significant results favoring the use of high flow compared to conventional oxygen therapy in these patients at low risk. Well, traditionally, risk for extubation failure has been classified into different groups: patients at low risk, those with none of the previously described high-risk factors for extubation failure, and high-risk patients, those with at least one of these high-risk factors. So the direct comparison between high flow and NIV after extubation in this group of patients is been published in this paper. This was published last year. Well, when we initially designed this trial, there was no strong evidence for the use of NIV in this group of patients. This slide refers to the guidelines that we used for this design, published by the Canadian Society in 2011. And well, the guidelines suggest, it's just a suggestion, but suggests that you can use NIV after extubation, scheduled extubation of a patient considered at high risk, but only in centers that have expertise for this technique and for this indication. Thanks God, recently, a new guideline has been published by the ATS and the American College of Chest Physicians, and for the same point of care, conclude differently. They make a strong recommendation with a moderate quality of evidence, and this strong recommendation says directly that for patients at high risk for extubation failure that has been under mechanical ventilation for more than 24 hours, well, there's a strong recommendation for this preventive NIV. Well, I consider that this new evidence reinforce our trial because of the design. Well, additional information according to these strong recommendations directly says that using meta-analysis technology, well, there is a significant reduction in the reintubation rate when you use high flow, and the same for, when you use NIV compared to conventional oxygen therapy. And there is also a significant reduction in the intensive care unit length of stay, and well, there is also a significant reduction in short-term mortality. For long-term mortality, there's not a significant result, but obviously I consider this a trend toward a benefit for the use of NIV. So for the final design that we performed with a low quality of evidence, I think this new guideline reinforced our initial planning of this trial. We, for the original study, we performed a multi-center randomized trial, and we decided to design as a non-inferiority trial because obviously high flow has some physiological mechanisms for possible benefit, but the hypothesis never included a superiority analysis, and we decided a margin boundary of 10% in the difference in reintubation rate favoring the NIV. And well, the statistical methodology was unilateral 95% confidence interval non-inferiority trial. We analyzed two primary outcomes, reintubation rate and post-extubation respiratory failure rate. And well, one of the most important points when we designed this trial was to decide what are really the high-risk factors for extubation failure. We decided to use some of the previously used in randomized trial testing the NIV for this high-risk group of patients. And those include age, cardiac failure as the reason for intubation, the Patchet-2 score, the day of extubation, patients with not simple weaning, hypercapnic COPD patients after extubation, but we excluded patients who develop hypercapnia during the spontaneous breathing trial because there is a specific trial by a Spanish group, and that I think gives a strong evidence for NIV. And when we designed this trial, there was no information regarding the possible role of high flow according to the hypercapnic management. So, well, maybe at this time we probably could have included these patients, but not at that time. Patients with more than one comorbidity, those with problems to deal with respiratory secretions, and those with problems with ROA patency. These high-risk factors were used in previous randomized trials, but we considered that there was similar evidence for two additional high-risk factors not included in these trials. That is the body mass index, more than 30 points, and prolonged mechanical ventilation more than 7 days. So we finally used these 10 high-risk factors, but I have to confess that obviously there's not strong evidence. Those with more evidence are age, COPD patients and cardiac failure patients, but there is no validated and universally accepted model to predict extubation failure. So for the patients recruited for this trial, we obtained this. We had patients with 1 high-risk factors and up to 7 high-risk factors. And the most frequent high-risk factors we observed were prolonged mechanical ventilation, maybe the Patchet score, patients with more than one comorbidity, and those with more than 65 years old. And this is the distribution between the two groups, so it's similar. And the main outcome of this, well, for the two primary outcomes, the reintubation rate, we obtained a non-significant result. So we can confirm that high flow is non-inferior to NIV in this group of patients regarding to the reintubation rates. And for the other primary outcome, post-extubation respiratory failure, surprisingly, we observe a higher number of patients failing in the NIV group. Well, that was a surprise, and we had to think about this result just to try to explain it. And maybe the reason for that can be well, analyzed with the reasons for post-extubation respiratory failure rate analysis and the same for reintubation analysis. We observe a higher number of patients in the NIV group that had post-extubation respiratory failure secondary to respiratory acidosis. And well, this is obviously the opposite as expected when you use NIV in these patients. And the reason for that maybe is that NIV is not a comfortable device for these patients. I want to remark that the indication is a preventive. These are patients without extubation failure at the time we start with this technique. And well, the protocol included the use of NIV for 24 hours, but the real time under NIV was really 14, and the most important reason was intolerance. And well, another mechanisms for benefit was reduction, non-significant reduction in the post-extubation failure rate and reintubation rate in patients with problems dealing with respiratory secretions. Maybe these are the two most important mechanisms for benefit. So well, this is the Kaplan-Meier curve of this original study. I just want to say that, as you can observe in this blue line, this is just few hours after the switch off of both therapies, NIV or high flow. But in the case of high flow patients, there is a sudden increase in the reintubation rate, suggesting that, well, maybe if you increase the time under high flow, maybe you increase the benefit. That's just an hypothesis. Just want to say that there is room for improvement, maybe when using high flow for this indication. And well, after these results, we try to obtain different subgroups that could have a different behavior according to the use of NIV or high flow. There is a previous study published in 2004 in Intensive Care Medicine Journal, and the most important result of this study is that, well, the higher the number of high-risk factors a patient has, the higher the risk of extubation failure. So maybe the classification into different groups of the risk of extubation failure could not be adequate, or at least the most adequate. And according to this hypothesis, we perform a post-hoc analysis. A post-hoc analysis trying to analyze if the risk of failure for both therapies, NIV or high flow, depends on the number of high-risk factors the patient has. So we perform, this is a complex statistical analysis. This is an effect modification and interaction analysis using two different scales, an additive with the risk difference interaction and a multiplicative scale with the relative risk radio interaction. And after, this is like an univariate analysis, and after the equivalent to multivariate, this is an adjusted model with a normal linear regression analysis for the additive scale and a Cox model for the multiplicative scale. This is, well, according to the recommendation for presenting this kind of analysis. So with this analysis, we perform this, well, we obtain these results. In this figure, you can see patients, you can see patients with 1 high-risk factors, 2, 3, up to 7. Above the dashed line, all these points means that there is a benefit for MIV in terms of extubation failure, and below this dashed line is the same, but the benefit is for high flow. So we obtain these results that patients with 1, 2, or 3 high-risk factors for extubation failure had a clear benefit using high flow instead of NIV, but the opposite for the patients with 4 or more high-risk factors for failure. So we can say that with this analysis that we can confirm the non-inferiority of high flow compared to NIV in patients that we could consider at intermediate risks of failure, that is those with 1, 2, or 3 high-risk factors, and those patients at really high risks for failure, 4 or more high-risk factors, maybe, well, the non-inferiority could be not safe, and well, maybe there is a benefit for MIV. This is the additive scale, and it's a significant analysis, and the same for the multiplicative scale, with also statistical significant results, reproducing the same results. 1, 2, or 3 high-risk factors. High flow clearly is not inferior to MIV, and 4 or more, it's not sure this conclusion, so maybe there is more benefit for MIV. Another way to try to obtain different subgroups of patients regarding a possibility of different roles of high flow and NIV, we perform a different post-hoc analysis that is just comparing directly every high-risk factor for extubation failure. And well, we use an effect modification analysis. This is referred for reintubation. And we obtain no different results for any of the high-risk factors except for body mass index, more than 30, that is obese patients, that the clear benefit for NIV is superior in terms of reintubation rate. And well, we try to confirm this result using an adjusted model for the additive and multiplicative scale. And in both cases, we obtain a statistically significant result. So this, in my opinion, generates the hypothesis that obese patients, independent of the number of high-risk factors, can benefit with the use of NIV. And according not to reintubation rate, but for post-extubation respiratory failure rate, we perform the same statistical analysis, and in this case, we observe different results. No difference for any of the high-risk factors, except for patients with problems to deal with respiratory secretions. In this case, the result was opposite. That's the benefit was for high flow and not for NIV. And well, we confirmed this result with the adjusted model in the additive and multiplicative scale with significant results in both cases. So this result, in my opinion, generates the hypothesis that patients with problems to deal with respiratory secretions could benefit with the use of high flow, mainly because of the condition in the air and favoring management of secretions. But this is an hypothesis that should be confirmed in a specific randomized trial, obviously. So to conclude, my first conclusion is that probably we should better classify the risk of extubation failure in 3 groups and not in 2. These could be low patients at low risk, those with none of the high risk factors, patients at intermediate risk, those with 1 to 3 high risk factors, and these patients clearly can be safely under high flow because non-inferiority is strongly confirmed. And the third group, patients at high risk for extubation failure, those with 4 or more high-risk factors. And in this case, well, I currently could recommend better NIV because non-inferiority could not be strongly confirmed. And 2 additional conclusions, just to trying to obtain specific groups of patients according to the specific high risk for extubation failure, that those obese patients could benefit with the preventive use of NIV after extubation in terms of reintubation rate, and patients with problems to deal with respiratory secretions could benefit with preventive use of high flow in terms of post-extubation respiratory failure rate. And well, thank you so much. I'll be happy to answer your questions. Thank you.
Our next speaker, also from Madrid in España, is Federico Gordo, who's going to talk about electrical impedance tomography. Federico, you have the floor.
Bueno. Hola a todos. Hola Nial, mucho tiempo sin verte. Sé que hablas un magnífico español, así que no habrá problema con la presentación en español.
And I know that you understand Spanish, so you can understand me
sobre
perfectly.
la
I
ventilación
will
con
talk about
tomografía de impedancia
electric
eléctrica para ver
impedance
cómo la utilizamos
tomography
en la
to
práctica
optimize
clínica
ventilation, to see
y
how we
transmitiros
can
la experiencia clínica que
optimize it in the clinical practice and to show you our experience in using this technology to monitor the patients. These are my highlights. The management of the mechanical ventilation in patients must be customized with basic monitoring of the ventilation. As it is done now, it's not enough, but we can settle lung mechanics and improve the prognosis, or at least prevent further damage with ventilation. Mechanical ventilation is always associated with distress, but not only ARDS exists. Other patients also need to be managed properly because 90% of the patients have other pathologies that are even more complex than ARDS. So what's the problem now? When I have to manage this patient, I have to ventilate a specific patient. So the clinical trials are useful to a certain extent. In this case, this patient has a lung injury that can be heterogeneous, but according to the clinical trials, we know, according to the experimental trials, the patients have different phenotypes with different different feedbacks and different reactions to the same treatment. So when I analyze my patients, the first decision I have to make is whether the lung is recruitable or non-recruitable, because this will, of course, allow me to choose one or another treatment. So I have to make a decision as to the mode, the total volume, and the PEP, which are the methods we use. So how to approach the patient? We all know the recommendations published by the ATS, but the recommendations are international, but look like they were written by my friends, because they talk about limiting the total volume, they talk about limiting the pulse pressure, they talk about using the prone position, which is not commonly used in the clinical practice. And as for the PEP, it depends on what. And what about the ECMO? And they say, well, we have to see, because we don't know how to use the ECMO, or if the ECMO is going to be used or not. So my recommendation is to customize the treatment and prevent further damage. So we have seen the ART trial, an international trial performed by many countries, different contexts. It was very complex and very, well, it has to be credited for, because it's complicated to organize such a large trial. It will be very difficult in Spain, for example. But this trial showed an increase in mortality related to the use of recruitment maneuvers and the PEP titration according to compliance. This is against what we thought and what we talked about customizing, and they said that we mustn't use the ARDS network for low PEP. The problem is that this trial has some setbacks or problems. It is a very valid trial, it is efficient, but only 10% of the patients use the prone position. The results are quite weak. Of course, the patients were selected. Only volume-controlled ventilation modes were used, not the pressure-controlled ones, so the results are very weak. Because, in my opinion, mortality is not statistically significant after 28 days. By using finer analysis, we could obtain different evidence. We have analyzed the mechanical power induced by mechanical ventilation in both groups, and we saw that in recruitment group, if we don't have into account the recruitment maneuver, we can see systemically more mechanical power in the intervention group as compared to the control group, and this can explain the supposedly higher mortality in one group than the other. But in any case, the trial is to be thanked for some reasons, some things. Contrary to the recommendations, it is telling us that we should use more PEP in our ARDS patients, and this is the real contribution of the ART trial, because if we use PEP with CO2 above 0.9, we have to use PEP above 15 if the VO2 is 1. So don't raise your hands, but can you please tell me how many of you use PEP in your patients with 24 when the VO2 is 1? The trial says that you have to use the open lung, you have to get your patients open and use PEP, because the lung said that we're not using these PEP levels in the clinical practice. This is the PEP level that corresponds to the low VO2 level, so we're not using the PEP enough. So what do I have to do with my patient? In my clinical practice, I think I have to adjust the mechanical ventilation to the lung mechanics of every patient. We have to use advanced ventilation monitoring systems, and of course we need to have a ventilation protocol. Our ventilation protocol We've been using it for 4 years, and we call it ventilation with empathy because we have to, we take the patient into account. We see how they interact, how they react to the ventilator. The maximum opening is a functioning lung. We search for a maximum opening and lowest distension. We try to decrease the mechanical power. We try to use spontaneous breathing in the early stages of the distress, and we try to get a homogeneous distribution of ventilation because we want the air to get everywhere in the lung where a gas exchange can take place. And these are some examples where you see the first thing we saw when we started to use the impedance ventilation is that we're using too much ventilation. Patients who have some ventilation can breathe normally. This is a patient with a peritonitis sedated with midazolam. We're trying to get a tidal volume less than 8 milliliters per liter. And this is the CPAP we want to get. This patient is on noradrenaline, 1 microgram per kilogram per minute, and the continuous VV hemofiltration, and sedated with midazolam and fentanyl. Dr. Blanche will talk about it later. He will talk about spontaneous ventilation and the risks with some ventilation models. But if we do this without the patient having an increased ventilation and breathing work with an impedance tomography, and we can see the homogeneous ventilation in the whole lung, we can be sure that we're not damaging the lung, we're reducing the mechanical power and the distension pressure, and this patient was extubated after 72 hours. The impedance tomography also helps us estimate the effect of the pulmonary recruitment maneuvers. This is a recruitment maneuver performed by our group, and you can see the increase in the functional residual capacity of the patient and the effect before and after the maneuver, with clearly an improvement in ventilation in the posterior parts of the lung. So we can clearly see which lungs are recruitables and which ones are not. This is the maneuver described with Giacomo Bellamy, maneuver with PEP adjustment, with recruitment maneuver, and without. It's like you two, with or without you. So it can be done with recruitment maneuver or without recruitment maneuver. If we do it, well, we can see how using one or another the scores increase or decrease. And this is a patient, a female patient, 54. I'm not going to reveal her name. She's on chemotherapy with nosocomial pneumonia, with distress, but the pathology is unilateral, monolateral. And this is the pH, the PaCO2 and the PaO2, the FiO2, the driving pressure, the PEP. You can see all the results here. So this situation is shows an indication for ECMO, but according to the trial, the ART trial, we should keep the PEEP between 18 and 24 water. So we use the impedance tomography, and with it we can see the heterogeneous distribution of ventilation. One of the lungs is completely cancelled by the pneumonia, is not working. It's not receiving air, so the distribution is completely heterogeneous. So we are increasing the PEP, as what the international consensus say, but with the PEP the lung opening is quite moderate. We create more distension pressure and more damage to the lungs, so the maneuver is not quite efficient. If we see it, there is no elevation of the residual pulmonary function. At least we cannot see any improvement in our targets. only stress, so it is over distension. This is not what we were looking for. So in this case, since we know the maneuver, we put the patient into a prone lateral position because of the heterogeneous distribution. So we got this lung opening at the base of the left lung, and we got this noticeable increase of the residual lung capacity and the distributed volume on the left lung, the one that was completely closed, without inducing any increase on the right lung. That was a normal lung, and we didn't want to get any over distension in the right lung. We could see a spectacular increase in the pH and the PO2, and of course an improvement in the ventilation. The PCO2 was reduced in the gasometry and in the ventilation analysis. So we reduced the compliance of the lung and the data for the mechanical power, because we took away some distension pressure, we reduced the tidal volume, we ventilated the patient better, and we adjusted the ventilation parameters. So after 3 hours of this prone lateral position, the oxygenation changed, the ventilation changed. We don't need any more permissive hypercapnia, and we got a homogeneous distribution of the lung. We opened the lung and all the ventilation areas. After 24 hours of prone, the PO2 and the PO2 ratio was 350. We're not going to publish it because it's not an ECMO case. It is very fashionable now to publish cases of critical patients with sudden improvements in ECMO, but this is not ECMO, and we have to search for very precise indications and to see what patients can really benefit from an adequate ventilation maneuver and other extracorporeal techniques. So, why is impedance tomography important for us?
Because it allows us to improve the handling of our patients, and we can include the term homogenization of ventilation. It allows us to achieve a functional lung, to improve the ventilation of patients, and to adequate the rest of mechanical ventilation parameters. We are estimating the level of ventilation, the volume, the PEEP level, to see how we are performing the lung recruitment maneuvers. It allows us to work every day with our patients when they are in bed and have a monitorization parameter. And in the future, we will be able to determine perfusion of patients. We will be able to adjust ventilation and perfusion. The electric impedance tomography is being developed. You can see here the change which is not produced when an experimentation animal is put in prono position. The distribution of the ventilation would change, but not the perfusion. With prono, we take the air to the area where the best ventilation is. I like to put the data of our unit, 105 patients on MV due to ARDS. Our mortality now is 25% in our hospital. The mortality in the ICU is 20%, and we try to see the ventilation of our patients to try to achieve homogenization of their ventilation, like the grasshopper that you see here. Thank you very much for your attention. Thank you very much, Federico.
To diminish patient-ventilator asynchronies, and I would like to start with my conflict of interest, of course, since I am inventor of one patent to monitor, for a system to monitor waveforms in that case, and also I am founder of a startup with my corporation. So then I would like to start with this image of Tobin. You will see here of the Tobin book, where this is a patient that fights with the ventilator. I mean, this patient has absolutely open eyes, is sweating, cyanotic, tachypneic, abdominal paradox, using all the muscles to inspire and expire. And up to this point, I mean, this patient, I'm sure, presents dyspnea or any type of respiratory sensation like air hunger or need for more airflow, discomfort, delirium, anxiety. Probably this may cause lung injury, muscle injury, and perhaps increasing mortality, as now we are investigating. And all patients in the ICU present, in that case, asynchronies. This is, I mean, from our work in my group, this patient present asynchronies all the time, and in the day 6, the patient 1, this patient a little bit on the, let's say, at 3 days, completely during the whole stay, the patient 3, and at the beginning, the patient 4. So this is totally, in that case, unpredictable. So you can find this in this review that now will appear in respiratory care. So the different classification of asynchronies based on inspiratory period, which could be trigger delay, I mean, inspiratory flow mismatch, then phase asynchronies, or reverse triggering, then the transition from inspiration to expiration, double cycling, due to short cycling or reverse triggering, and also expiratory muscle contraction due to prolonged cycling, and during the expiratory period, mainly ineffective effort. So I would like, first of all, to review which is flow dyssynchrony, when the inspiratory flow is not enough. I took that slide from John Marini because I believe it's great. This is a passive breath where all the work is done by the ventilator. Here it's called machine work. And below you will see how when the patient starts, I mean, inspiration, I mean, there is part of the work, subject work, which is caused by the patient. If the patient is pulling hard because the flow is not enough, the patient will do the total work of breathing. And then we must know to treat this type of asynchronies to understand the relationship with inspiratory time and airflow. In spontaneous breathing patients, ventilator inspiratory time should be equal to patient desired inspiratory time. So this is a fundamental, this is one of the foundations for mechanical ventilation. We must ventilate the patients according to the brain of the patients, not according to our brain or according to a new mode that somebody told us that it's great. Because spontaneous breathing and the inspiratory time usually is less than 1 second. If the patient has a high ventilatory demand, inspiratory time is as short as 0.5 seconds. So we need to fulfill that need. An inspiratory flow mismatch occurs when the ventilator fails to meet, in that case, the patient's flow demand. Here you have an example that this patient is breathing, I mean, is doing a little bit of work of breathing, but in certain breaths, because patients breathe in an heterogeneous form, I mean, this has a profound flow mismatching here because the ventilator does not fulfill the inspiratory demand of the patient. So we need to pay attention, in that case, to the screen of the ventilators, because when we are detecting this flow starvation, here there are inspiratory efforts, then we need to do something. Fernandez et al., I mean, and Yonis published that paper, which is really nice because it tells what we must do at the bedside. These are tracings of airway. So let's see how the patient is doing lots of work of breathing, flow, volume, and here electrical activity of the diaphragm and the muscular pressure. Here in A, there is, I mean, a huge inspiratory flow mismatch. Then when the inspiratory flow is increased, you will see here how there is better matching between the neural inspiratory time and the flow needs, in that case, of the patient. The ventilator fulfills that, and then there is less, in that patient decreases the work of breathing and decreases the electrical activity of the diaphragm. So to conclude that part, inspiratory flow mismatch, we must to increase or to look at to increase gas flow, try pressure regulated modes, decrease respiratory drive, assessing adequacy of analgesia and sedation, but this is the third measure, not the first, and then check for dyspnea. So I'm sorry for that. Dyspnea, it's very important. We need to ask to the patient. Look at that article recently published in the Blue Journal saying that, I mean, 2/3 of the patients report breathlessness, and clinicians and nurses, we underestimate, in that case, dyspnea, so we need to ask to all the patients whether or not they have dyspnea, because patients cannot talk, so we must ask to them. So here you can see a combination of flow mismatch that in that case, I mean, originates what we call double cycling or double triggering or breath stacking, whatever definition. Now we need to find the definition. So here the patient is pulling hard, as you will see. And since the inspiratory time of the patient is longer, in that case, than the inspiratory time set in the ventilator, there is a double cycling. So the second breath, in that case, is more or less passive, but the first breath, the work is done by the patient. But this ventilator allows an extra flow, but also there is double cycling in the second breath. As a consequence, this patient is increasing 150% the tidal volume, which is lung protective. So this asynchrony probably is one of the worst asynchronies. This asynchrony can occur in any modes, in pressure control, with minimal exhalation, so 2 inspirations without expiratory phase or a little bit of expiratory phase. Now you will see the volume doubles, the volume doubles, and in volume control you will see here that also plateau pressure in that case could be higher. So perhaps this is one of the asynchronies that we need to pay attention, because some people now relate this with the ventilator-induced, in that case, lung injury. How to treat? I took that paper from the group of Jesse Hall and Chankes. They did, well, what to do when there is breath stacking, as you will see here. No intervention, maybe sedation or ventilator adjustment, and interestingly, increasing sedation does nothing, and when we apply the knowledge, and in that case, this patient switches from assist control mode to the pressure support with a little bit of more tidal volume, which originally is 400, but be careful, here is 800, because there is no expiration. I mean, this is the characteristics of the ventilator to avoid drift. Don't be misled by that. Tidal volume is double, here with a little bit more. I mean, this asynchrony is, in that case, avoided. We also need to pay attention to the new asynchrony, now better described by Kumianaki and Brochard and Richard, saying that ventilator breaths, in that case, can trigger a patient inspiration in the middle of the ventilator insufflation. This is a characteristic that may be because there are neural reflexes or maybe a spinal muscle reflexes that can do that, and you will see here how this is a machine breath totally, and the patient breath is triggered in the middle. This can occur without breath stacking, double cycling, or double triggering, or in that case, I mean double cycling or double triggering. And usually there is an entrainment, in that case 1 to 2. So when the patients present that, and now we know more, maybe this happens during several hours, and probably this we must treat that. So to conclude that part, double cycling, we must, to increase ventilator in inspiratory time, we need to try pressure support, titrating flow termination criteria to improve synchrony, or maybe proportional modes, and maybe in huge cases consider paralyzing agents. So double cycling to reverse triggering, decrease sedation, check respiratory rate, and also consider paralytic agents if tidal volume is too elevated, like in the examples that I presented to you. So now we are in the half of my talk, to ineffective efforts. Ineffective efforts, it's what you see here, when the patient tries to get a breath and simply cannot trigger the ventilator. This happens in volume control, this happens in pressure control, and this is the most frequent asynchrony in patients under invasive mechanical ventilation. So ineffective efforts, as you will see here, is an ineffective effort. There is a breath, usually, I mean, this inspiratory effort is not like this, and then, I mean, there is no pressure support breath. What are the causes of that? Obviously, is too much assistance. In that case, too much pressure support, because the patient gets hyperinflated, and then this effort is not enough, in that case, to trigger the ventilator. Another one is the presence of auto-PEEP, because with this effort, patients cannot counterbalance auto-PEEP, inadequate triggering, or the cycling off, which is, in that case, the pass from inspiration to expiration, in that case, in pressure support. So looking at the bedside, if the patients are hyperinflated or not, or whether the cycling of is okay and adjusting, I mean the pass from inspiration, in that case to expiration, adjusting the cycling of according to the mechanical characteristics of the lung, the group of Brochard, in that case, decreased the asynchrony index, in that case by decreasing pressure support and adjusting the cycling off. So we at the bedside, without any, I mean, esophageal balloon manometry at the bedside, we can just looking at the patient and knowing what are the factors do something for much comfort to the patient. Another issue is to look at, in that case, look at the auto-PEEP. When there is auto-PEEP, I mean the patient must counterbalance off that pressure, and if we counterbalance auto-PEEP with external PEEP, then the patients with a minimal effort can trigger the ventilator. This has been nicely pointed out again by the group of John Marini, and here we have an example. Here is a pressure support. There is here an ineffective effort. This is esophageal pressure, and you will see how, with this auto-PEEP of 6, this inspiratory effort is not enough to cycle the ventilator. When the Mancebo and co-workers compensate auto-PEEP by external PEEP, ineffective efforts disappear, and the work of breathing of the patient is much, much less. So be careful with sedation. Sedation is the worst thing for ineffective efforts. I took that paper from Brochard and co-workers, when in pressure support they use light sedation and deep sedation, and they observe that with deep sedation, ineffective effort not only not disappear, but they are incremented. We as a clinicians, maybe we see the patient more calm and sleeping, but we are decreasing, in that case, the electrical activity. We are decreasing the inspiratory effort, but we are not decreasing the frequency, so as a consequence, there is a lot of ineffective effort. So please, don't use sedation, or if you use sedation, please take a look at what's going on. In that paper, when they switched to NAVA, where any electrical activities followed, in that case was by a pressure assistance, ineffective efforts, in that case, disappear. So treatment of asynchronies, in that case, ineffective efforts, check trigger sensitivity, this must be done always, check excessive air trapping, check for excessive assistance, which is excessive set frequency and or inspiratory time during controlled modes, or excessive pressure support, counterbalance auto-PEEP, always check for dyspnea and maybe consider proportional modes. So this is the final part, phase dyssynchrony. Sometimes there is a mismatch between the inspiratory time of the patient and the inspiratory time that is set in the ventilator. And as you will see here, when the inspiratory time of the ventilator, the patient is still, it's inspiring, and then what we see is there are two competing flows. Since the ventilator opens, and this is passive to atmosphere, and the patient wants to get some air, this peak expiratory flow, in that case, is amputated, and this can happen similarly in pressure and volume control, and in that case, in pressure control. You will see here another ineffective effort. So, this is in pressure support. Since patient breathe heterogeneously, inspiratory time is not the same. You will see how, these breaths are more or less, there is a matching between patient's inspiratory time and ventilator inspiratory time, because the cycling off criteria is quite well. But in this breath, the inspiratory time is the patient is prolonged, and as you will see here, that the ventilator ends before the patient, and there is a competition in that case in expiratory flow. So the opposite can also happen. When there is the inspiratory time of the ventilator is longer than the inspiratory time of the patient, and when the patient tries to expire, still the ventilator in that case is in the inspiratory phase. So what the patient does, competes and tries to expire, and they cannot, so there is this increase in pressure due to the activation of the expiratory muscles. This can be seen here in this is esophageal tracing. The patient finishes, in that case, the inspiration here, not the ventilator, so patient tries to exhale, cannot. And in this diagram of the Tobin paper, you will see exactly the same. When the patient tries to expire, the ventilator is still in this inspiratory phase, so this is the activation of the expiratory muscle. So, to correct that, short and prolonged cycling, again, we need to look at what's the inspiratory time of the patient, what's the cycling off, so we must increase or decrease the inspiratory period. We need also to check the cycling off in pressure support and maybe use of proportional modes. So, this is my team. Without them, I cannot be here talking about asynchronous, so thanks to you, to everybody, and the people in the world that is listening us. Thank you very much.
Okay, thank you very much, Luis. A very nice overview of asynchrony. So now we have time for questions and discussions about all three of these excellent presentations. We heard, just to refresh our memory, we heard about the use of high-flow nasal cannula, particularly in the setting of avoiding extubation failure. We heard about the use of electrical impedance tomography and personalized mechanical ventilation, and thinking about mechanical power. And we heard a lot about thinking about dyssynchrony and how to minimize that. So I'd like to first invite questions from my two co-panelists, Bruno and Emmanuel. If there are questions to any of our speakers, please go ahead.
Okay. Thank you very much, the organization, for the invitation to take part in this great initiative. And my point is to Dr. Hernandez. And it's well known that non-invasive ventilation is a useful tool in many conditions. But however, when it fails, the outcomes of the patients tend to be worse compared to the patients who were ventilated invasively right from the beginning, not going through a non-invasive period. And what I'd like to know is, the same point could be a concern when we are using the high-flow nasal cannula. Thank you very much.
Well, in the case of a preventive indication for high flow or NIV, our recommendation, because to our knowledge there is no model predicting high flow failure, our recommendation is to use during fixed periods of time. In our case, it was 24 hours because of some local concerns, but maybe benefit could improve using up to 48 hours. But you should use high flow during a fixed period, whatever you choose to use, and using pre-specified intubation criteria. And we never use NIV as an escalation therapy between high flow and intubation. In our two trials, we checked the time to reintubation in patients failing, and there was no difference between high flow and conventional oxygen therapy in the low risk group, and no difference between NIV and high flow in the high risk group. So, well, under these conditions, I think it's as safe as conventional oxygen therapy and NIV.
Thank you.
Okay, thanks, Gonzalo. Emmanuel, you have some questions for the group here?
Hi. I'd like first to congratulate the organization and the very high quality of the talks. I had a question for, I think it's Luis. It's rather really difficult for the physicians to recognize asynchrony, and I think it's highly complex, and you're very expert in that field. But what would you advise for the clinician lambda to in the way to approach the screening of asynchrony or over assistance, for example? I think over assistance delay from the ventilation, and you've shown nicely also that asynchrony has consequences. What would you advise as a step-by-step approach for the clinician lambda to detect these anomalies and resolve them?
Thank you very much for your question. I believe that nowadays we still do not have widely used computerized system in that case to advise in both to detect asynchronies and yes. Approaching asynchronies requires, a full examination first, the patient. Looking at what are the patient characteristics that can promote certain asynchronies. So look at, the disease, respiratory mechanics, and all that. And after that, you need to see the patients together with the screen of the ventilator and see whether, there is a matching between inspiratory time of the neural inspiratory time of the patient and the ventilator. Then we need to assess, the flow needs of the patient. And then with all this, decide what type of the treatment is the best for the patient. Usually, at the beginning, people is using according to, some statistics, volume control or pressure control, so we must assure that there is no flow mismatch. When we switch in that case to, pressure support or more proportional modes, in that case, we must really to adjust, in that case, the not to over-assist, adequate external PEEP to counterbalance if there is any auto PEEP, or to keep, certain increase in expiratory lung volume, and also in that case, in pressure support, to ascertain which is the good cycling off for the patients. And then if the patient is obstructive, cycling off will be high, maybe 45, 50. If the patient is restrictive, is low. But then with the chair, the most important thing is a chair to sit down in the middle of the patient and the ventilator until the patient is satisfactory. And after that, if the patient is a little bit conscious, we must ask to the patient, do you have dyspnea? Are you comfortable? Do you have, hunger of air? For any respiratory sensations that we can improve comfort.
Thanks, Luis. I like that an essential piece of equipment is the chair to really park yourself in front of the ventilator.
Yeah, can you hear us?
Yes, I can. Yes.
Yes, I'm Guillermo Ortiz from Bogotá, Colombia. We're a group of physicians here, and we have a question here.
Okay, go ahead, Guillermo.
Thank you, Dr. Hernandez. Have you seen any difference in sedation requirements between the non-invasive ventilation and high flow cannula? Is possible to reduce sedation requirements even a week?
Well, our protocol includes high flow and NIV after extubation, and is because this is a preventive indication. We do not include sedation to improve comfort in patients. What I can say to you is that comfort is really higher in the high flow group. All the patients were under high flow as per protocol 24 hours, but that was not the case for NIV. The patients were under the real time under NIV was close to 50% of the time by protocol, but we never use sedatives to improve comfort in NIV patients when it's indicated as a preventive therapy. Sorry, I cannot answer your question.
Thank you, Gonzalo. I have a question to follow up something for Federico Gordo. Something you said towards the end of your talk, Federico, about monitoring perfusion also with electrical impedance tomography, because I think one of the limitations of currently of EIT is that we can see where there is aeration or changes in impedance, but the question is whether we've recruited functional lung. And so I think the addition of perfusion monitoring to that would be a major advance. And I'd like to know if you have any inside scoop about when that will be coming, or have you played around with that as yet? Or how will that change how we use EIT?
Yeah. Thank you very much for your question. I think perfusion can help us in the future, because we can see the coupling in both terms. Nosotros podemos ajustar la ventilación mecánica, no solo ajustar el volumen donde lo llevamos, sino que podemos saber dónde llevar ese volumen, dónde es funcional. Hay pacientes en los que la perfusión no puede tener. Perdón, ¿me oyes?
Puede seguir.
¿Me oyes?
Sé que le oyen, ¿eh?
Sí.
Sí. There are lungs that can have a distribution that is not a homogeneous one, perfusion distribution, the same as ventilation distribution. And we can work in the future to couple both systems. I don't know if this is working. Do you hear me?
Sí, entendemos.
Okay, thank you.
Bueno, hay otros preguntas desde la audiencia en Madrid o
There
en Bogotá.
are there any other questions from Bogota or in Madrid? You can speak English if you want.
No, we don't have any other questions. Thank you very much.
No hay más preguntas, gracias.
Maybe I'll ask one more question
Voy a lanzar una pregunta más a Luis.
Luis, do you ever worry about in trying to focus on synchrony? Sometimes that may be actually increasing the amount of potential for lung injury that the patient is exposed to. Now, I understand curing double triggering, that's a different phenomenon, but in a patient who's on pressure support and breathing spontaneously, sometimes when we try to make them more synchronous, that results in them taking larger or more frequent breaths, which could increase the mechanical power to which they're exposed. What's your thought in balancing the goals of synchrony versus lung protection in a spontaneously breathing patient?
I mean, the group of Georgopoulos, and now we have shared both databases, our database and Georgopoulos database, we have found both, I mean, that clusters of ineffective efforts, if they occur very often in a short period of time, has enough power in that case to affect outcome. So this needs to be confirmed in larger database. So if you have short periods of a lot of ineffective efforts, maybe this is wrong. So shall we avoid ineffective efforts? I mean, we can, in that case, avoid ineffective efforts by doing low assistance. But if you do that in patients, I mean, then, and they have, I mean, a lot of air hunger and dyspnea. And if you over-assist, you have ineffective efforts, but the patient are under perhaps more comfort. So to me, a little bit of ineffective efforts, probably nothing happens, and is tolerable by the patient stays in a comfort area, and probably is not injurious. If there is lots of air hunger, I mean, we have the hypothesis that maybe this will affect your post-ICU cognition and so, and we need to investigate that. And if you have lots of ineffective efforts because you are over-assisted, maybe this has consequences on outcomes. So a little bit probably is not wrong, and if the patient is comfortable, to me this is, in that case, I mean, the best way. But this is my opinion. So it's what we say, no evidence, just expert opinion. And again, as you like it, the chair is not from me, it's for all intensivists. The chair, again, you know, is the issue. I mean, to control those patients until the patient is comfortable.
Excellent, thank you, Luis. Obviously, it's when we're into the realms of opinion-based medicine is maybe the more interesting parts for discussion, which is good.
Okay.
I think, and the organizers can correct me here, but I'm wondering whether it's time for us to move on to the next session. I think we are over time somewhat. We started a little late.
Yes.
We could continue discussing these for some time, but Pablo, maybe you can tell me, are we ready to move to session 4 now?
Yes, Neil. Thank you very much for your moderation. Thank you all the lecturers and panelists, and we have to move on to the next session. Thank you very much.
Okay, good luck with the rest of the day.